Okay, welcome everybody to this meeting of the Health Overview and Scrutiny Committee. The meeting's taking place in Spark and Ho Committee Room today, but some officers will be joining online via Microsoft Teams, so I can hear some feedback. Can we make sure all microphones are switched off?
Speaker, I think, that needs to on.
My microphone.
Thank you. Yeah, so just to confirm, whether you're joining online or in the room, microphones off when you're not speaking, and then turn your microphone on when you are speaking. Thank you very much. So I think Mrs. Newton's got a technical problem, which I'll just sort out. Just a second. Okay, Mrs. Newton sorted now. Yeah, so we've got some new members of the committee this year, so I'll just like to welcome you all. Mr. Charlesworth, Mrs. Newton, Mr. Hills, Mr. Harrison, and we've also got Rosita Page, who's substituting for Mr. Phil King today. And I'll also welcome back the Cabinet Lead Member for Health, Mrs. Richardson. So we'll move on to the first agenda item, which is appointment of chairman. At the annual meeting of the County Council, Mr. Jonathan Morgan was nominated as chairman-elect. Can I have a proposer and second that Mr. Morgan be nominated chair? Thank you, Mr. Harrison. Thank you. Everybody happy with that? Thank you. So, Mr. Morgan, you are appointed chairman of the committee for the 2022-23 year, and I will hand over to you for the rest of the meeting.
Thank you very much, Ewan, and thank you very much for the nomination and seconding. So we're now on to item 2, which is the election of vice chairman. Do we have any nominations? Dan? Okay, thank you very much. Do we say a seconder, Aziza? Thank you very much. Is everyone happy with that? Yep, that's everyone. Great, thank you very much. So Mr. King has been elected as vice chairman. Okay, item 3, minutes of the meeting held on the 2nd of March 2022. Propose that the minutes of the meeting held on the 2nd of March are taken as read, confirmed and signed. Is everyone agreed? Everyone's agreed. Okay, thank you very much. Question time. So we have received one question from a member of the public, Mrs. Foster, who I can see on screen in front of me. Good afternoon, Mrs. Foster. So Mrs. Foster has sent a question which has been answered, and the answer has been sent to Mrs. Foster, and that answer has been published on the County Council's website. So I'll take that as read. However, Mrs. Foster, do you wish to ask a supplementary question to the main question that you asked previously?
No, I'm quite happy with that answer. Thank you.
Brilliant. Thank you very much, Mrs. Foster, and thank you very much for joining us as well, and also for the question. Okay, we now move on to item 5, which are questions asked by members under Standing Order 7.3 and 7.5. No questions have been received from members. Item 6, to advise on other items which the chairman has decided to take as urgent. No items have been presented. Declarations of interest. Can I ask whether any members have any declarations of interest they wish to ask? Mr. Hills.
Thank you, Chair. Although it's not really coming up on the agenda that I've noted, I do work as a dentist receiving income from the NHS, and so just thought that would be on the record.
Brilliant. Thank you very much. Mr. Newton.
I just want to declare that I have family members, it's about 3 of my children working in the NHS locally too.
Okay, thank you very much. Any other declarations that anyone wishes to make? No, absolutely none. Okay, thank you very much for both of those. Item 8, which is declarations of the party whip. Are there any declarations of the party whip? Probably aren't. No. So item 9, which is presentation of petitions. There are no petitions to be presented. So we're now on to the meat of the meeting. We have 5 papers that we have before us this afternoon. As usual, we'll take all the papers as read, so we have the opportunity to go to debate and discussion and questions, etc. As soon as possible. The first item we have relates to the National Screening Programme, which has been written by NHS England. Here to present it, we have David Giffard, who I think there is, on my screen in front of me. Good evening. Good afternoon, rather. It feels like evening in this room. All the curtains are shut. But good afternoon. And also Stephanie Cook, and I can see Stephanie as well in front of Chatsworth by the looks of it. Is that Chatsworth, Stephanie? Yes, it is. I thought I recognised my stately home, so I love Chatsworth. So, Stephanie is Senior Public Health Commissioning Manager at the NHS England, as is David. So I'm going to ask you, either or both of you, whether you wish to sort of do a 30-second summary of any of the points that either aren't in the paper that have subsequently become available, or alternatively, if there are any points in particular that you wish to highlight from the paper, or if you're happy, we'll go straight into questions and debate. Up to you, David and Stephanie.
Thank you for your kind welcome. I'm happy to go straight into debate. I had prepared a bit of a briefing, but I think it would take me longer than 30 seconds. So if the paper is taken as read, I'm happy to go straight into questions.
Okay, that's fine. Stephanie, you're nodding as well. Okay, that's great. Look, it was a good paper to read, nice and clear. So thank you very much for that. So always helpful. So I think one of the, I mean, the paper seems to present quite a good picture of recovery on the screening side, and I think obviously very, very good to see. From those in the room, I suspect that probably quite a few of us have probably had experience of NHS screening at some point over the last 2 or 3 years, and I suspect that probably on the whole, most of that's probably been quite positive as well. So personal experience is always quite useful to have. Obviously, we also have a great deal of feedback from residents. And I have to say, I haven't had a huge amount of negative feedback about anything to do with screening programs or the continuation of. So again, that seems to be reflected, I think, in probably the sort of positive stats that are presented in your report. Are there any questions from the committee on the report? Mrs. Newton.
Thank you very much, and thank you very much indeed for the report. I think it's a very challenging time for the services due to COVID-19, and I just wondered whether or not the screening services, when we will see a return to full service for the screening service department. Thank you.
Okay, if I'll take that answer. So the paper describes that there's kind of 6 screening services. There's 3 cancer, 3 non-cancer. 2 of those services continued throughout the pandemic. That was antenatal and newborn and cervical screening. Yes, we did have some challenges with those, but on the whole, they maintained their services throughout. The aortic abdominal aneurysm service has already recovered. The bowel screening service has already recovered from the pandemic. It is rolling out to age extension. It rolled out to 56-year-olds last year. We intend to roll it out to 58-year-olds this year. This is a government commitment that is over a 4-year period. So that is going well. The diabetic eye screening service, we intend that they will have recovered fully by either the end of this month or failing that mid-July. And the breast screening service should have recovered fully again by July. So we are either in a situation where the services have fully recovered from the pandemic, or they are very close to being recovered. So they have had challenges undoubtedly, and they will continue to have challenges while we live with COVID, but they have worked fantastically to get to the position they're in, and we are in a good position in Leicestershire.
Thank you. That's very helpful, Chair.
Okay, thank you very much. So I've got 2 other questions. Mr. Charlesworth, followed by Mr. Page, and then Mr. Hills.
Thank you, Chairman. Yeah, like you, I've not had really any feedback from residents concerning screening programmes or delays or missed appointments. So that's positive. I can speak from experience. Being diabetic, I have eye screening every 12 months, and I barely noticed a blip in the service. I think end of 2020 I was due, and they saw me in February. So from my experience, there was no real problem at all, and I've been going for about 12 years now. And it mentions the delay because of COVID restrictions. I didn't really notice that either. I know it says 30 minutes, but they seem to have a well-oiled machine at my surgery, so I've got no complaints whatsoever. So on that, it's very positive. Thank you.
Thank you for that kind feedback. Yes, they certainly did have some challenges with regard to the social distancing and the requirement that their appointment times were longer with the eye drops. Interestingly enough, I'm also a diabetic, and I've had 2 diabetic screenings during the pandemic, and like you, I haven't noticed any decline in service provision whatsoever. So despite the challenges they've had, they have done what they can, and their appointment times are going to improve massively now that social distancing is being relaxed for their service. So they will get even slicker.
Okay, thank you very much. Mrs. Page, followed by Mr. Hills.
Thank you for the report, really positive, and ditto to what everybody else said. My question is rather parochial. The bus, breast screening bus, has not attended Lutterworth, and I was just asking, will that be reinstated or will that be a permanent measure?
I believe that the situation we've had during the pandemic, the breast screening service has had to kind of prioritise particular sites, and have also had difficulty in accessing some sites. My understanding is that once they have recovered, they will be looking to go back to the screening sites they used to previously use, which should include Lutterworth. But I will double check that for you, and I will come back with a response to confirm that.
Thank you, much appreciated.
No problem.
Okay, thank you very much, Mr. Hills.
Betty and Rosita, do you mind turning yours off? Because mine.
Oh, sorry.
Oh, sorry, I had no.
There we go, perfect. Thank you. Obviously, the report's really welcome that services are going back to normal in the immediate future. My question was, looking back at the history, what has been the knock-on effect of disease rates and severity?
Sorry, could you just repeat that question, please?
Yes. So obviously during COVID, there's been a reduction in screening. Have you seen an effect on, disease rates and severity?
Unfortunately, with a knock-on in delay in screening, yes, there has been a situation whereby cancers have been missed, late diagnosis. There has been a piece of national work to look at that and consider what the impact of that will have been. And when all of the services across the country have recovered, there will be a piece of work to consider the ultimate impact of the pandemic. Obviously, it's not just screening services, as you're well aware, it's affected all health services. And unfortunately, it's been challenging for the patients accessing these services. We will be following that up, though. Health equity is a big part of what we want to look at going forward, and we just needed to get these services in a recovered position before we could move on to look at levels of uptake, the number of patients who've been delayed, the impact on them, and what we can do to address that going forward.
Abby, would you like to come back? No, that's good. Okay, Mike Sandys.
Yeah, thank you, Chair, if I may. I was going to ask Dave, just thinking about sort of post-COVID recovery, are there any groups or communities that are now less likely to come forward for screening, be it cancer or non-cancer, than they were before the pandemic? Obviously, there was always a sort of inequalities and uptake before the pandemic. I just wonder if that's been exacerbated during the pandemic for whatever reason. I think it sort of also sort of ties in with the previous question too.
Yeah, unfortunately, I think it probably has. Which is why there is so much focus now on looking at health inequalities as a result of COVID. We've got established groups within NHS England and working with wider stakeholders to try and get a handle on exactly what issues have been caused by COVID from an equality point of view and an equity of access point of view, and looking to see what we can do to address those. We are keen to work with all of our stakeholders to kind of not just approach this from an NHS England improvement point of view, but approach this from a whole stakeholder, whole system point of view, engagement with the local authority, with the CCGs, with the integrated care systems when they're set up from the 1st of July. We have got evidence that it has been exasperated, and we need to look at schemes to understand that and to tackle and try and encourage people back to the programmes.
Okay, thank you very much. Okay, we've run out of questions on the report. So look, thank you very much to you, David, and also Stephanie. Good report to receive, but also thank you very much for answering the questions from the committee. So with no other points to go, I'm going to thank you both for attending, and we'll move on to the next item in that case.
Jem, could I just ask one question?
Yes, absolutely.
Would it be possible for me to join the 0 to 5 discussion later on in the meeting? It's just their services linked with ours. It would be
useful. No, absolutely.
So if I dial off now and come back in at 3, would that be okay?
Yeah, I mean we may
or
3 o'clock is probably about right. Or alternatively, if you just want to turn your camera off and sort of hang on in the background, then hopefully you'll notice this coming back to life, as it were.
Right,
okay.
Will do. Thank you very much.
Okay, take care.
Bye.
Right, we're now on to item 11, which is the primary care improvement paper. So hopefully appearing on the screen. Okay, so yeah, we have Faye Bayliss, who's Deputy Director of Integration and Transformation at Leicester, Leicestershire and Rutland CCG. Hello, Faye.
Oh, that was painless.
Well, I was actually hoping to my colleague.
Sorry, Faye. 1 second. David, I think you need to turn your microphone off because we can still hear you chatting. No, you just turn your microphone back on, David. No, now it's off. That's okay. Sorry about that, Faye. Otherwise, you're going to end up with a load of comments coming over you. Apologies.
No, that's absolutely fine. I was hoping that my colleague Yasmin Sidiat is actually going to present the paper. Ewan, I've just tried to dial her in, but I don't have authority to do that. She was due to join at 20 past, so she'll be on in 2 minutes unless we can dial her in. Ewan, thank you.
Sorry, I'm struggling.
She'll be here in a minute. I'm happy to take questions if anybody has any. If we're taking the paper as read, thank you, and I'll do my best until Yasmin, who wrote the paper, arrives.
If she's going to be turning up in the next minute or so anyway, then I'll probably do the preamble and then hopefully she'll appear on the screen in front of us. Okay, so hopefully Yasmin will be joining us in a couple of seconds. Yasmin is the Deputy Director, Integration Transformation City. And as I said, Faye is the Deputy Director for Integration and Transformation Leicester, Leicestershire and Rutland CCG. So paper seeks to set out where we are, obviously on sort of the GP service provision, primary care provision across the county. Again, as usual, I'll take the paper as read. However, I'll wait for Yasmin to join us because if there is anything that she wants to highlight or flag or any corrections to the paper before we start discussing it, then there's an opportunity to do so. How far are we? Okay. What time was she actually due on? I'm going to say the alternative phase, if we do the next item first. I don't know if you can get hold of her at your end. Oh, here we go. No. Wrong person.
I've just messaged her.
I tell you what we'll do the 0 to 5 now, which is the next item 12, and then we'll come back to you in 5 or 10 minutes to take this item, if that's okay. Oh. Right. Okay. This is challenging everyone. Hopefully they're all there and ready. So what we're going to do, Faye, if you want to turn your camera off, and we'll come back to you. Oh no, here we go. Here's Yasmin. Look at this. Faye, come back. Right, there you go. Yasmin appeared suddenly as an admittance.
Hi.
Here she is. Fantastic. Yasmin, good to see you.
Nice to see you too. I was unsure because I was just trying to connect, and I'm not in my usual place of work today, so apologies.
Don't worry. IT is always challenging, let alone when you're trying to join a meeting like this one. So thank you very much for joining us. So I had just done a few opening words about who you are and the paper, and also about Faye. We are taking all the papers as read, but what I'm going to do is give you the opportunity, if there's anything that come up subsequent to the paper being published that you want to add, or any sort of little bit of explanation that you feel a particular part of the paper maybe would benefit from, then I'll give you sort of 60 seconds to do so. Otherwise, what we'll do is go into the discussion and questions, etc. As soon as possible. So up to you. If there's anything you want to say, then by all means do.
Yeah, so just very quickly, one of the things I did want to pick up with the committee today was with regards to and the enhanced access. So it relates to the access part of the plan that's in the paper, but these are recent developments around primary care networks and their responsibility to deliver enhanced access from the 1st of October of this year. So it's a national directive with regards to this, and we're working with our primary care networks in terms of the delivery of this. The reason why I mention it is because I'm sure people will be aware, or they will have seen a survey or questions that they've been asked to complete and submit. So members of the public, by their GP practices and their primary care networks, will have been asked to complete that over the last few days, and you may have been contacted by your constituents, etc., with regards to this. So I just wanted to mention that. And again, if there are questions relating to that, I will pick those up as well today.
Okay, thank you very much. I suspect some of the questions will probably be on that theme as well. So that's quite good timing in that case. Look, I'm going to open this up to question. I know GP access is a continuing theme of quite a lot of discussion for councillors here. We get a huge number of queries from residents about access to their GPs, certainly over the last couple of years. And I think it's probably fair to say there is still a general perception that accessing primary care is still very difficult, particularly face-to-face access. One of the things I'd quite like to actually open, and then I'm going to pass to Mr. Harrison for the first question. Under the paper, there's reference to appointments, and particularly there's reference to the number of appointments being available being greater than pre-pandemic. Can I ask, what's the definition of an appointment from your perspective? What does it cover?
So the definition of the appointment and what it covers is appointments by the GP and other healthcare professionals within the practice. Those appointments are a mixture of telephone and non-face-to-face, and also the video consultations where video consultations are available. So it will cover those. It will also cover same-day appointments, and it will also cover pre-planned appointments as well.
Okay, and in that case, do you have a breakdown of those appointment types? Because I think that's probably maybe what people are referring to when they talk about appointments. They're probably talking about face-to-face appointments, and it'd be useful to actually understand the comparison between where we are now and maybe pre-pandemic.
Yes, so we do have a breakdown, and I think in the paper I didn't talk about face-to-face appointments as opposed to non-face-to-face. So where previously pre-pandemic predominantly appointments were delivered face-to-face, we saw obviously quite a significant reduction of that over the pandemic period. We have seen a slow incremental increase, and currently 68% of those appointments are face-to-face appointments. So it's not back to where it was pre-pandemic, but also what we're conscious of is that we have got now a various means and ways of accessing your GP, and not everybody wants to have face-to-face appointments. So it's about now how we strike the balance on that and get to a place where we patients feel that they've got the type and level of access that is right for their needs.
Okay, thank you very much. I'm going to open up to the committee for general questions now. So, Mr. Harrison, you're first up, and then Mr. Hills, Mrs. Page, and then we'll pause at that point.
Right, thank you, Mr. Chairman. Good afternoon, Yasmin. Thank you for your report, but it wasn't, from my perspective, happy reading, sadly to say. I looked at it and read it through carefully, and there's lots of repeats within it, but the message of this is how you're going to reduce the workload for doctors, and this comes out continually through this programme. 25, while reducing the GP workload, 4 key points go down to B, reducing the workload, and the whole emphasis of it. Now, I feel very concerned about this because the National Health Service, and I only know how I experience it myself and what's happening with doctors and how they react. The head of the practice I go to attend said you'll very rarely ever see this waiting room full again. His words, not mine. So that was his version of it when I asked him about it. And I just find that going through it all and how they are setting themselves up from working from home. My wife is in a care home and had a fall, suffered from vascular dementia. And it was a serious fall. They rang the doctor and he said, well, I'm working from home, ring an ambulance. So 7 hours later, the ambulance arrived, which was fairly serious. And then the hospital agreed that it was a bleed on the brain, which made it even more serious. But all the time whilst attending the doctors, the other day I went in and there was three people or 4 people in a room that probably sit 60 people. And I just get the view continually that we are losing the NHS that my generation certainly enjoyed, being able to see how this actually works as a project, what it was initially instigated that you could go. I can remember you could go in the morning, the afternoons, the doctor would be visiting, in the evenings you could go again. Access was always freely available, but now it's been controlled and reduced. The town I live in is not a huge town, but they say to me, it's 2 weeks for an appointment. And I say, well, isn't that far too long? And they say, well, we have 19,000 people registered. And I just wonder what sort of business is going on. You know, I mean, obviously, if they've got more people part of the surgery, there's a greater income, and I accept if they're running it as a type of a business. But what they've got to remember, if they start to act like a business, maybe there's other business providers out there who could do a better job. So my concern is simply this, that the emphasis of your document, while valuable, explains in some detail what your endeavours are, but I fear the outcome is how you're reducing it for doctors. Now, what alarms me even more, Yasmin, is today there's an announcement that chemists are now going to be able to refer you for x-rays, potentially cancer. This was the announcement today, a whole range of other things. And at the end of the day, the doctors are now saying, well, if you've got this, got that, go see the chemist. And I just wonder whether sort of equipping themselves with a quasi type of doctor system that's sort of negating where they were originally. Yes, you could always go and see a chemist and he'd say this or that. But really, when you're talking about medical issues, and now we're talking about x-rays, the announcement today, I'm just getting more and more concerned that the doctors are distancing themselves from really seeing the people. A doctor is a person who sees somebody with an illness or a concern about their health. And I just think this document doesn't help someone like me. But I want to thank you for the work you put into it. Thank you, Mr. Chairman.
Yasmin, do you want to come back on some of those points?
Yes. So in terms of that, and I absolutely, understand, and what I'm hoping I have been able to do in the paper is be really upfront and honest about the challenges that we are facing. It is clear in terms of the fact that general practice, what it was and what it is at the moment, is changing. And over the last 15, 20 years, that change has been very incremental and very slow. So as a patient, as an individual, you won't have noticed some of those changes as much. But over the last 2 years with the pandemic, some of the changes that have been implemented have been quite significant and quite rapid. And what we have now is a recognition of general practice not being recognised in the way that it has been previously. And general practice traditionally has been about a GP, a general practitioner, doctor and patient relationship. Over the last 10 years, that has been changing slowly in terms of a wider healthcare team coming in to provide different elements of general practice. And that has generally been accepted. But I think what we've seen over the last 2 years, particularly with the pandemic and the introduction of the primary care networks, is there's been a real expansion of those of the different types of healthcare roles, and not necessarily taking people and public with us with regards to what does that mean, and how does that work, and how does that improve things. And I think there's a huge amount of work that we need to do. And apologies if my paper doesn't quite explain this, but I think there is the plan in terms of that is about making that much more clearer, and being very clear about the wider work, not necessarily reducing the workload, but we don't have as many doctors as we did previously. With the trajectories that have been set, we won't have any more doctors as we did previously. So it's about how do we utilise the doctor's time, how do we utilise the wider healthcare professionals' time in a way that addresses the needs of the patients. And in terms of the face-to-face, I think that's really important. And I think some of the points have been raised, particularly around some of the stories. I would like to be able to have the opportunity to take some of those away and go back with my general practice colleagues to look at how we do that differently. It's not acceptable for patients in care homes not being seen when they need to be seen. And if there are things like that, we need to pick those quality issues up and address them head on as well. So that would be something that I would want to do.
Okay, thank you very much. Mike, do you want to come in on these points?
Yeah, thank you, Chair. I mean, it's probably more to sort of stand alongside Yasmin in terms of presenting this, which I know I'm not a co-presenter. But Yasmin, I'm thinking, I mean, you know, that's the fundamental challenge, isn't it? We collectively in health run the risk of kind of talking about GPs and primary care, and we interchange things. But your point is well made, isn't it? Fundamentally, the family doctor that we knew 30, 40 years ago isn't there, and there are push reasons and pull reasons. There are reasons to do with more complex care, long-term condition management, where you need a broader range of people. And fundamentally, as you were saying then, there is just less GPs than there were for a number of reasons to do with, for instance, the influx of doctors that came over from Southeast Asia in the 70s, now getting to retirement age, et cetera, et cetera, et cetera. And I just wonder, when we talk about primary care network, I think there's a point about honesty, which is actually sitting down with the public, members or otherwise, and just explaining why it is we're going through the changes in primary care teams and primary care networks, as well as the kind of what we're doing. I just wonder if we'd lost the ability to actually just be honest and go, there are less GPs. So if you want to see somebody who's just as well qualified to deal with a level of problem, this is where you need to go. So I'll sort of invite a response whilst going on your side with this one, I think so.
No, thanks, Mike. And I think you've made the points really well. So I'll open it back to questions, because I'm conscious of time as well, and a number of questions which will probably be quite related as well to this point. So,
okay, thank you very much, Yasmin. Do you want to come back in, Mr. Howard?
Yes, thank you, Chairman. Yasmin, I understand, and I do get that, but government's saying this week there's so many thousands of doctors in training and all sorts. My thing is that without COVID, we'd still be going to see a doctor. COVID's brought in this thing where everybody wants to be at home, and there is a play on that, because prior to COVID, you could go and see a doctor. The second thing that concerns me is going to see the chemist. Now, you've been to see a chemist and he'll call your name out. You'll say, yes, I'm so-so, where do you live? And you'll give your address and you'll be asked for your postcode. Everybody hears it, who was ever standing there. Now we're talking about going and saying, well, I've got this, or I've got diarrhea, and I've got whatever horrible complaint you might have. I just think that I'm just really appalled that with, you know, if you've got a cough and he thinks, okay, have a lozenge, But, you know, to now say that they're going to recommend you for X-rays and other investigations, I just, you know, there's no privacy, because that was the whole thing of a doctor in a room. You had that privacy. So I just want to make this point that if it's related to COVID experience, I think it's poor show, because it didn't happen before COVID. You could see a doctor. 2 years later, everybody's at home and we've got another world, and it's just not the same. And that's my concern. But thank you for the way you've presented it. Thank you.
Mrs. Richardson, do you want to come in on this point?
Yes, thank you. I just wondered, Yasmin, is there a way of having a standardised way of doing, you know, for example, video conferencing with a patient would probably give far more confidence, say, than a telephone conversation. But not all GP practices have video, and yet it's quite a relatively cheap thing to change. So that was one of them. And the other thing is, we have so many different health professionals in the team now. Is there a way of having a publication or something that shows what all these people do, but also how they dovetail into each other? Because then residents can understand it. Thank you.
Thank you very much. Yasmin?
Yeah, absolutely. I think that's a point really well made, and that's one of the things that is a key action for us, is around providing that detail, but in a way that is understandable as well, so people, you know, Joe Public, you know, any one of us can pick that up and understand in terms of what, you know, what my general practice, what my surgery now consists of, and what does that mean. So we are working on that, and absolutely would want to be able to work with yourselves as well to make sure we get that language, the tone right on that as well, so people are able to understand that. So absolutely, the standardization element, this is one of the things that we do want to do. So very quickly, every single one of our practices across the LLR implemented a number of technology to be able to see patients virtually, for example, and the technology is varied, the infrastructure is varied, because they did it very quickly in a matter of months to be able to deliver the services that they needed to deliver. There's some work now to do to look at how we ensure that we've got consistency in that delivery and the standardization of quality in that delivery as well across all of our practices, but taking into account that one size doesn't fit all as well, that there are going to be, you know, members of our, you know, residents, our patients that are not going to be able to utilize that no matter what we do, so that provisions are in place that they are able to be seen face to face when they need to be seen face to face, but we have a consistent approach to that, and not a variation in that, which is what one of the key priorities for this year is to absolutely rectify that and get to a point of better standardization and quality.
Okay, thank you very much, Yasmin. Okay, we've got a series of questions coming up. So we've got Mr. Hills, Mrs. Page, Mrs. Newton. So, Mr. Hills.
Thank you, Chair. I think it's great that access is one of the 4 key priorities in the primary care improvement plan. But before patients are given an appointment, they need to be able to get in touch with the practice first. And, you know, we've talked today about, or we will talk about the tech behind the scenes, video calls, phone calls with your doctor. But if you talk to anyone in Hinckley and Bosworth in my patch, everyone has a story about how they phoned their GP up at 8 AM to get a same day appointment. They've been on hold for an hour just to be told all the appointments have gone, phone back tomorrow. Now, surely in this day and age, when we're all talking about the technological advances, what work is being done kind of front of house to make it easier for residents to just get an appointment in the first place?
Thank you. Yes, so this is one of the issues that we've had. So we've implemented things like cloud-based telephony, but cloud-based telephony is good if they've got people to be able to service those lines. So you can have as many lines open, but if you still only got 2 members of your admin team that manage and man your phones, you've still got 2 members of your admin team that manage and manage your phones. So one of the things we've been working with practices is about looking at how they they can work more collectively together so that they are able to answer those phones much more effectively. How can they pool their admin team across a number of practices and work together to be able to do that? So we've been trialing this with a number of practices in the city and the county to look at how that works, if that's effective. Does that actually enable them to, you know, have that front of house bit better managed so that patients don't feel that they're stuck on the end of a phone for a very long time before they actually get through. The other element to this is about the fact that once you do get through, so if you rang at 8 o'clock and if you're unfortunate enough to be 25 on the phone, and by the time you get through, the appointments are booked up. One of the things we've been working with our primary care colleagues is about understanding how they release their appointments throughout the day so that they don't have this constant cycle of you know, blocking all the appointments all in one go. So that's some of the other things that we're trialing and testing to see how that works. The other element to this is about online appointment booking, and all our practices have got the facility, but we are aware that not all of our practices have reopened that facility and opened it in a way that enables them to manage their patients as well. So a number of us will be able to, and quite happy to be able to go online and book our appointment, which would be much more easier to do and much more effective. It also means that you're reducing the backlog of people ringing on the telephone as well. So that's one of the main aims as well this year, is about getting all of our practices to consistently make sure that they have got enough appointments that they are making available, bookable online, that they are right sizing their same day appointments in terms of what they have available on the day, and also in terms of the advanced appointments. So this is if you need an appointment but not that day, for example, it's your regular health check, etc. You should be able to book that in advance rather than taking up a same day appointment for that. So those are the things that we are working on, but we're trying to do that and trying to get to a level of consistency across, you know, there's 72 practices in the county, but across 134 practices across our patch, which is quite a number of practices. And I think one of the colleagues did pick up on the fact that they are also individual businesses as well. So we've got to make sure that we get them to a place where we are able to tailor the services to what the needs of the local population is, but we get a consistency in approach. There's some things that can be done and are being done at the moment to make sure we are able to do that, but it's going to take a bit of time because it's undoing and unpicking a lot of custom and practice that has been in place for quite a number of years. And like I say, and then bringing in new technology that we have done, but the practice is not having the physical infrastructure, i.e. staffing resources, etc., to be able to maximise the opportunities out of that technology that's now available to them.
Mr. Hills.
If I could just come back on that, yeah, I think there's some very interesting ideas there. For example, releasing appointments throughout the day, so there's not that kind of jam at 8 a.m. right in the morning. I think you kind of answered what the crux of my question was in terms of the other ideas. You know, that's a very, very common suggestion, is why can't I book my appointment online? I appreciate it's not for everyone. You know, not everyone can use the technology, not everyone has access to the internet or a laptop, but most people can these days. So I think that's hopefully the way forward, in my belief. Thank you for that.
Thank you very much. Actually, your question prompted me to check my GP because I haven't actually had to book an appointment for a couple of years or so. And we have an app in my GP surgery in Loughborough, and I just went on, had a look at the availability of appointments, and actually the first pre-bookable appointment was actually the 1st of July, which is 2 weeks off. I have to say, pre-pandemic, it was 4 weeks. So actually, I was pleasantly surprised, I have to say. But again, being able to actually pre-book in advance for meetings or face-to-face meetings that are not emergencies has actually always been quite helpful. So yeah, I mean, certainly every GP practice should have that facility. I suspect they don't have to supply the technology themselves. I'm sure it's off the shelf, and no doubt something that the PCNs can organise between them. So yeah, no, good prompt. Thank you for asking the question. Okay, Mrs. Page, I think you're next.
Thank you very much, Chairman, and thank you very much for the report. Now, I hear the arguments, and we are in a time when never has there been more money invested in health. Yet, you know, we're cutting back on GPs and management staff. And I find that this whole report, like Councillor Harrison just said, is very concerning, and because it's all about avoiding work, handing more stuff over to managers and cutting down on GPs, which of course would then be a larger profit margin to whoever it is. Now, in my opinion, it is very, very important that mental health is also addressed. And when you have a very large constituency like mine with aging residents who are not totally afraid of using the technology, it is, you know, a whole total aspect. And following on my Councillor Hill's, even if you don't get in the second day, then you might not get the first day, you might not get in the second, and you might not get in the third. And for me, prevention is paramount to an early diagnose, because it's less costly in terms of resources to treat, but also to save lives. So it appears to me, and if you're going to, other reports and key indicators, that if we are focusing on IT technology and we're losing the personal contact, the prevention aspect and the early diagnosis are under threat. Now, I believe this report, and I hope this is only the beginning, and there will be a second report that gives us timescale, monitoring, flow charts of actions, and how this is all going to pan out, because all I have got is a lot of rhetoric, but I haven't actually got any actions. Who is going to do what, when, and what are the improvements going to be, and how they're going to be monitored. So I'd like to see that, and I'd like a comment on that. You talk about surveys. Now, let me tell you, my residents are afraid to fill out surveys. They're afraid to complain because they're afraid of reprisal. They need the health service. They complain to me, but what can I do about it other than sitting here and highlighting it? You then, if you're looking at receptionists and managers, they are not trained. They're giving advice or trying to fob you off. Now, in fact, sometimes they're downright rude, yet they are being, you as a patient are not allowed to raise your voice. I had a resident who was accused of lying, and indeed, on a personal basis, my receptionist did not even want to send my results to the wrong email address, but refused to send them to the right email address. Now, I think there needs to be a lot of more dovetailing over the services. There needs to be far more appointments available. There needs to be a different mechanism, but if it is so important that doctors have got and want to reduce their workload, why aren't we looking at triaging with paramedics and making another pathway available? So, and I'll leave it for there and see what the answers are.
Okay. Thank you. In terms of the questions, and I'll try to answer, and if there's anything that I've missed, just remind me in terms of that. Is just in terms of trying to think of my thoughts. Having just referenced back to the paper, I think one of the things that's been picked up is the expected benefits of the work that we would do around the workforce, which was reducing the workload. It's not about reducing the workload any further of general practitioners. So it's not about making general practitioners do less, but it is actually about getting our GPs to do the work that needs to be done by GPs by enabling our other wider healthcare professionals to pick up the work that can enhance the care and treatment of patients and the management of their long-term conditions much more effectively. So I think I wanted to just make that point and highlight that point. Language may have been a little bit thingy in the paper, so I apologise for that, but it's not about overall or any global reduction in workload of general practice, but it's about better management of workload in general practice and particularly of general practitioners. So I've just reread that paragraph again as part of the questions that I've been asked to make sure that I've covered that up. In terms of the access issues, as I've already repeated and said, which we've worked through with regards to the work that we need to do and where we want to get to over the course of this year and what we need to do for the subsequent years as well. There are some very specific issues around variation, and I think what the council and colleague has picked up is that variation in the ways in which practices deliver their services, and that's one of the things we really want to tackle, because quality care is something that's really important, and making sure that that quality of care is consistently good, and that we don't have practices delivering services in a suboptimal way is really, really important, and we need to make sure that we're working through that. The feedback that you guys give is really important for me to take back with my team to then look at how we address some of those variations. And we're already doing quite a big significant piece of work, particularly around the quality elements, so that we are making sure that GPs and GP practices are triaging and managing their patients in the right way, using the right personnel, and that they are trained appropriately to do that, so that we don't have patients feeling that they are being fobbed off or being not managed optimally, or that the staff are not recognising their needs in the right way. So there's some work to do around that. And again, I think this comes back to that communication. It comes back to how we are providing that information around what, the type of people that are now consistent in general practice, but also working with agencies like the Royal College of General Practitioners, etc., to really work with our local general practitioners about how they improve that quality and drive the quality element of their service provision. So that's one of the things we are doing this year, and we're working quite closely with the Royal College of General Practitioners to really look at how we address those variation across our 134 practices and really start to manage the quality much more better than has been previously. So that is a piece of work that we are doing. Apologies, because I'm sat in a room where there's all of a sudden a lot of people walking through. I may have missed some of the questions that have been asked, but if you can just repeat anything that I may have missed.
Yes, I will. Thank you very much. Will there be another report where we have looking at more detailed monitoring, timescale and positive outcomes? The next question was, has anybody, or are you looking at triaging with paramedics to enhance that and using it? The third one is evaluating individual practices, and another question which I just thought and I've gotten to ask, can you explain the appendices, because they make no sense to me and I don't know what they mean. Thank you.
In terms of bringing up a follow-up report, I think that would make sense, particularly in terms of the plan, but also in relation to and in response to the recent publication of the Fuller report as well, which outlines some quite significant transformations and changes for general practice. So I think if HOSC is is able to, then I would like to be able to do that later on in the year and bring that report. So absolutely would be able to do that. In terms of triaging with paramedics, so we, through the primary care networks, as you will have seen in the paper, there are a wider range of roles, and one of those roles is paramedic roles to support practices around being able to manage particularly minor illnesses and minor ailments, and some of those triaging aspects. So we're working with our primary care networks about how they utilise those roles much more effectively to support some of their triaging, but also managing some of those lower levels of ailments, etc., with patients that could be better managed by those types of professionals. So that is in there. The appendices, as per the paper, are supplementary bits of information where if I'd have included it in the paper would have probably made the paper much larger. So what I've tried to do is then provide that in the appendix around what the primary care networks are, where they are, and where our GP practices are located in terms of their location, where they are, and some of the details around that. So that's what the appendices has. The other appendix that's in there is the 15 new roles that exist within primary care through the primary care networks. So it was just giving a list of those new roles that have now come in. And that's the bit of work that needs to be done to describe what those roles are and what they do in primary care now as well.
Just 1 second. So if we're looking at Appendix A, there is no reference to Lutterworth. And if we're looking at Appendix C, for instance, so that gives us the additional operating hours or the present because it says current extended access services across Leicestershire. So
yeah, Yasmin, if I just come in, I'm assuming not every GP practice is actually part of a PCN.
They are. So every single GP practice is part of a PCN.
So
we do have the Lutterworth one, so I will double check that and then I'll resend that information. I'm just looking at the paper at the same time. So
yeah,
I suspect there's a page 2 missing, maybe.
Yes. And the last one, are individual practices are evaluated as, say, case studies, whether, how they're performing, etc., etc. And with that, I am finished and I really appreciate your answers. Thank you.
Okay, Mrs. Page is going to retire to the pavilion and have tea, I think. Okay, Mrs. Richardson, you had a quick point that you wanted to come in on there.
Yes, sorry, Jasmine, can you just, you mentioned care navigators for when people are coming out into, when they're in the community for other needs other than medical. How do you dovetail into our local area coordinator? You've said that you've taken the roles, the idea and the, the method of that, but are we doing things twice or are we doing different things? Thank you.
Yeah, no, thank you very much for that. So those roles are also working in hand in glove with actually your care coordinators, because they are now forming part of what's called the integrated neighbourhood teams. So what we're not doing is duplicating the work, but what we're trying to do is through the integrated neighbourhood teams work in those locality areas is getting those PCNs to join up with their with the wider workforce in terms of making sure that we're not duplicating. So there is that work going on as well with regards to the integrated neighbourhood teams. I've not probably put that in the paper, but I'm happy to provide information with regards to that.
Thank you.
Okay, thank you very much. We've got one question from Mrs. Newson, then I'll come back to Mr. Hills, if that's okay. Mrs. Newson.
Thank you very much. First of all, it's a commendation to say that the Nhs app, I use that, and I think it's an excellent tool that you have. And but I just wonder how well it's being used and how well you've publicised that you have the app. My question really is about currently there's 7 county GP practices with an active CQC. They're on the risk improvement list. I just wanted to know what percentage of GP practices are these 7, and also what is being done to bring them up to a better standard of performance. Thank you.
No, thank you for that. So I can't give you the percentages off the top of my head, but I can certainly get that information for you. In terms of the practices that are sitting on our risk register, you've said we have a team of people that work with those practices on an individual practice basis. That consists of our nursing and quality colleagues and colleagues from my team as well. And this is where we've also brought in the Royal College of General Practitioners to really support and supplement the work that we are doing with general practice currently to look at those practices, understand their issues and challenges, and then work with them to look at how we improve. Where we consistently don't see improvement, we do take further action with those practices as well. So I want to give some assurance that we don't just do lots of hand holding and helping work, but actually where we do need to take further action and ensure that we are doing right by those patients, that we will do that, and we'll work with the Care Quality Commission quite closely with regards to that as well, and ensuring those actions are delivered.
Okay, thank you very much. Okay, got one question from Mr. Hills, then the final question will be from Mr. Charlesworth. So, Mr. Hills.
Perfect, thank you, Chair. My question follows on from Betty's, more about technology as well. And it's a question, a bit of a comment at the end as well. I think when it comes to the NHS, it can get quite complicated quite quickly, you know, with abbreviations and pathways and networks and all sorts of things. But actually, what sometimes is most important is the simple things. It's great that the chair can go on his app and book an appointment at his GP. Now, and there's talk of promoting digital skills with local GP networks in the paper. What works incredibly well in my area is the Newbold Virgin Medical Centre. They have a Facebook page. And actually, if anything goes wrong, you know, the IT system goes down, the phones on reception are down, they'll just put a little comment in the Newbold Virgin Facebook group and say, look, we're really sorry, please bear with us. It's going to be a tough day, but the phones are down. And everyone understands and appreciates that. So I would highlight, Yasmin, that whilst it's great to look at all the high level technology stuff, actually sometimes those small kind of Facebook skills can really help out as well. Going back to the high level technology though, I'd just be interested, and you might not have the figures in front of you, but do you know what percentage of phone calls and video calls that practitioners are making, either the resident doesn't turn up or virtually doesn't turn up or they can't access, or how many of those aren't happening?
I haven't got that data to hand, but I can certainly look at the data and get that information and send it as a post-meeting note.
Okay, thank you very much, Yasmin. Mr. Hills, I'm one of those without a Facebook account. I'm absolute heathen when it comes to IT. So apologies. You've just isolated me completely. I'm insulted. Okay, Mr. Charlesworth, final question.
Thank you, Chair. Yeah, I agree. Facebook, spawn of the devil. But that's just a personal opinion. Thank you, Yasmin, for the paper. It's informative. I'm new to this committee, so if I'm asking naive questions, do forgive me. I've got one comment and a couple of questions. I think pharmacists do have a role to play. They're trained health professionals, and I think there's a role for them, and I think they're underutilised. And in terms of privacy, most pharmacists I know have a room where you can go to and have a confidential conversation with the pharmacist with whatever concern you may have. And I think that is a way forward to help. It's not the sole solution, but it's certainly a way forward. In terms of, I'm trying to understand numbers. The chair mentioned about face-to-face appointments, and it says in our paragraph 10, 68% are recorded as face-to-face. Is that the person and the GP in the same room, or is it face-to-face on a screen?
It's the person and the GP, or the person and the nurse in the same room.
Thank you. And then going back, I mean, it's nearly 400,000 appointments in March 2022. Were they all GP appointments, or were they with nurses as well? And how many of those were missed?
So I haven't got the DNA rate on those, so I can certainly get that. But I think I said it earlier, the appointments that are there, they are a mixture of doctors, nurses, and other healthcare professionals that are part of the GP practice appointments. I can get you a breakdown. I didn't provide it in the paper, but can certainly get you a breakdown in terms of how many were GP and how many are nurses and other healthcare professionals.
That would be useful, please, Yasmin, because, you know, we're never going to go back to the way it was before COVID. I think the days of going to your GP and having 20, 30 minutes with them, they're gone. We're in a new world now, and we need to change.
Your GP is obviously not busy enough. I've never in my life had a 30-minute appointment with my GP. I wouldn't know what to talk about. I'd run out of things.
Don't think I've ever had one in my whole life.
No,
you know, my
I'd love to know where your GP is. But anyway, look, that has been an extremely useful session. Thank you very much for that, Yasmin. We'll definitely come back to this. This is obviously it's an area of huge concern for all of our residents. You know, using primary care is critical to people's well-being, mental and physical, and getting it right, improving it, making it as porous and accessible as possible is absolutely critical. But people need to feel comfortable that they can actually access the services and the right services, and feel that you know, they are being treated correctly. And as such, we'll definitely have it back at this committee to talk again and find out what improvements have been made and what else is being planned. So thank you very much, Yasmin, and thank you very much for all of those for taking part in the questioning. Okay, look, we're going to move on to the next item now. Oh, the screen's suddenly gone completely. Have we lost absolutely everyone? No? IT, don't we just love it? Fantastic. Indeed. So look, we're on to item 12. Can I ask Helen and Colin whether they wish to actually join us up at the table? Thank you very much for joining us in person and in this twilight room. It might be sunny and glorious outside in Leicestershire, but in this room it's 3 o'clock in the morning in a nightclub somewhere in the city. No, I was going to say I haven't been to a night. This is what I imagine nightclubs to feel like, Betty. I don't really know. I haven't been to one in such a long time. I wouldn't know. So look, we're on to item 12, recovery in the 0 to 5. So we'll say under 5. I think is probably the easiest way of describing it. Under 5 health visiting contacts and transition. I appreciate under 5 actually in this terms actually includes pre-birth as well. So 5 and under. Helen Thompson, Director of FYPC and LD Services Leicestershire Partnerships NHS Trust, and also Colin Cross, who is the Service Group Manager for Healthy Together. I think we also have Kelly online. I can see Kelly's circle. Is Kelly going to appear as a video? Look at that. It's amazing. This technology actually works. So Kelly Marie Evans, who's our Public Health Leicestershire here at the County Council. So thank you very much for you're like big sister sitting over us, Kelly, at the moment, watching what we're doing. So thank you very much for joining us. Again, we'll take the paper as read, but by all means, if there's anything in addition to what's been presented in the paper up to now, maybe something new that's come out since the paper was published, by all means, have an opportunity to raise that with us now, or if there's anything in the paper that you really would like to highlight because you think is actually a sort of key point and maybe it hasn't come across in that way in the way that it's been presented, by all means, if you want to do that over the next minute or so, then that's fine. Otherwise, we'll go straight into questions and discussion about the paper. So over to the two of you, three of you.
Thank you, Chair. That's lovely. Thank you. So yeah, Colin, subject matter expert, and myself, who's the Director of Service. It was really just summarising the points. So Leicestershire Partnership NHS Trust, who Colin and I both work for, are responsible for the delivery of the Healthy Child Programme, which is the universal preventative and progressively targeted services for children and families up to the age of 18 years, 25 years for looked after children and those with special educational needs and disabilities. And we work very closely with Mike and Kelly as the commissioners of that service, the public health commissioners on behalf of the local authority. Obviously, the paper sets out the 5 mandated contacts. I think it was really just about reflecting on the past 2 years, and which has been a really challenging 2 years for children and young people services, essentially because the response that we were required to give around the March to April 2020 was around standing down and prioritising and stratifying all of children and people services to release staff to go and man adult wards. Essentially, that was the expectation, which we successfully did. We released a number of staff, over 70 staff, and we redeployed a number of those staff onto adult wards. It wasn't until June, July time that we were then looking at how we started to restore some of our services, and it was very impactful, isn't it? Because obviously that, you know, we were focused on the response to COVID and also setting up the vaccination centre, which we did within our directorate at the People Centre in Leicester City. So since that time, we've been restoring the full service offer in a phased way, in line with national guidance and in consultation with Kelly and the team. The rate limiting factor, and you'll see it played out every week in the news, is access to a workforce supply. And essentially, our mandated contacts, whilst we would have gone quicker, we would have been faster. However, we've seen a number of staff retire in response to COVID and their experience over the last 2 years, and we haven't been training enough registered nurses to come in and pick up those jobs. And you've seen that play out, you know, in the news every week. And we're no different in Leicestershire. You know, we're looking really creatively at how we train our own, grow our own workforce from support worker into qualified nurse, and then into a specialist community public health nurse as a health visitor or a school nurse, because they have to do another year's training. So we have fully restored 3 of the 5 universal contacts with performance at pre-pandemic levels. And we agreed with public health leads to restore the 2 to 2.5 year check before the 10 to 12 month check, because we've missed a number of children at that 10 to 12 month check, and we wanted to make sure that as kids are transitioning into school that we'd identified their needs, because that's a critical part in terms of readiness for school. And you've got a number of with obviously Jane Moore and the team here, you've got a number of readiness for school indicators for checking that children have had their needs identified, particularly special educational needs and disabilities. So that's why we re-established the 2 to 2.5 year first. And we are currently using the deprivation deciles to target our available resource for the antenatal contacts and the 10 to 12 month reviews. And Colin knows more about the pre-pandemic antenatal contacts. You know, were fairly low. It wasn't as though we were at 100%. You know, there's that wasn't an offer that was fully accessed by families. So we've got a plan in place to restore those services universally by the end of this calendar year, which will include greater use of skill mix with assessed competencies, and also securing local estate to establish more clinics, you know, people accessing us and not necessarily us accessing preschool early years settings as much as we did. And the plan's being overseen by public health leads with Kelly and Sham, and we have monthly contact meetings. So that was really just sort of it in a nutshell, our journey over 2 years, which has been quite challenging.
Okay, thank you very much for that, Helen. So actually, you've sort of slightly touched on one of the points I was going to raise, which is actually to do with workforce. I mean, I think every organisation, whether it's public sector or private sector, it is really struggling at the moment to fill posts. There's a certain amount of churn on staff, in the sense of people, I think, have been given time to think about their sort of life wishes, and certainly, you know, some retirements have probably been brought forward as a result of that, and it has created significant holes in many service provision. In the paper, you seem quite confident about workforce planning being under control. I think many organisations would probably cut off their right hand to actually have that sort of confidence. You've touched it on again verbally just now. How much of the return of the service to sort of catch up and be back to full strength is wholly dependent on that workforce plan absolutely working precisely? Because I think we're all of us slightly worried about our own respective teams, and making sure that actually we fill those posts, we recruit successfully, etc., to actually then be able to fulfil what our intentions, good intentions, as far as service provision is concerned.
So it has been incredibly difficult, and I think one of the issues was we're very heavily reliant on the specialist community public health nurse. That's our, that has been the core to the offer. We had a call to action a number of years ago where we massively increased. That was a national drive to do that. Of course, losing those, since then, really we've had a kind of decline since that moment. But what we've recognised is that there is available workforces within Leicestershire, and it's about tapping into those. So we've changed the model to be less reliant on that specialist public health nurse, and looked at skill mix. And one area which we've been successful in recruiting to is using nursery nurses that are very, very well versed in child development. In fact, experts in many ways. I've worked with many myself as a health visitor, and being able to upskill them to be able to do a safe and competent job around assessment. So what we've done is moved away from a model that's heavily reliant on a workforce that we can't replenish, and move to one where we think we've got a chance of doing that. And actually the recruitment into those posts has been very successful. And we've also reintroduced some registered nurses, the entry-level registered nurse, which is a band 5, back into our workforce. Actually, that was only quite a small proportion, pre-pandemic. We've increased those numbers, and actually there is a willingness, probably because of the work in the acute. Working in the acute has been difficult over the last 2 years. Many of those nurses are looking at a community placement, community role as actually being advantageous. So we are using that, to our advantage. That's not to say that there won't be difficulties along the way, but that we feel that that's a much more robust, realistic plan.
Okay, thank you very much, Colin. Right, can I open up for questions, general questions? Dan, sorry, Mr. Harrison, sorry, apologies.
Thank you, Mr. Chairman. Listening to your report, it's most impressive. I like the idea that you're looking at the labour resource, because we're told now with unemployment's down to 50 years since we've had anything like this. So it's extremely hard for anybody to employ people and to find the right sort of people. So listening to the initiative of what you're bringing forward, I think brings great hope in my mind, that you're not sitting back and saying, well, we're fishing in the pond all the time, we just don't catch anybody. So now you're going about it in a different way. You're looking at what is available, how you can upskill, is it reliable, is it safe, can it work? And obviously you're proving it now as you've got the system working bit by bit. So I think that is first class, and it's really encouraging to hear that, because I was expecting a different version, in a way that we're okay now, but tomorrow, because you hear that in a lot of places. Yeah, we're okay now, but what about tomorrow? So that's quite good, and I'm really impressed, and I'd like to thank you for that and encourage you to carry on and do more. Thank you.
There we go. Thank you very much. So I don't think we have any other questions by the looks of it. The paper was obviously very, very good. I think Mr. Harrison summed it up very well, which is actually, it's a very positive paper. It is an area that I think we'd had for obvious reasons, and you've covered it. The great deal of concern about the missed of 2 years, and your comments, Helen, in particular in relation to focusing on sort of catch up on the 2.5 year age group before, I think is absolutely critical. It clearly is. Every now and again, there's a huge amount of noise in the national press about, there has been in the last week, about how children are turning up to school and functionally not being where they should be, etc. And I think all of us probably have been subject to residents concerned, but not necessarily understanding the fuller picture. And to actually see what you've been doing is quite reassuring. As Mr. Harrison pointed out, also, the comments there about being able to tackle long-term workforce issues, I think is again very impressive to hear that there is a coherent and well thought through plan for that. So really, really good to hear, and thank you very much for joining us. And we do appreciate seeing you in person. So thank you very much. Okay. Well, no, well, thank you very, very much, and pass on our thanks to your team as well. Okay, excellent. No, she's gone now. There we go. Thank you. Goodbye. You return to daylight now. Okay, we'll now move on to item 13, which is the public health strategy for 2022-2027. It's the first time that we've seen a public health strategy from the County Council, so lovely to see it. We have Adrian Allen, I think, on screen. Oh, there we go. Adrian, you're there.
Hello.
The technology works, fantastic. So Adrian is Head of Service Design and Delivery here at Public Health in the County Council. I think this is your baby, Adrian, as much as anyone else's. So yes, you're here to answer questions. We also have your willing assistant, Mike, who's here to answer any of the easier questions that you wish to throw at him. And also obviously Louise as lead member. You're there at the front of the document, Louise, and I know you're very, very proud of the fact that this strategy has come together. So it's great to read and great to see. So thank you very much. Now, look, normally we're taking all documents as read. Obviously, it's extraordinarily well-written document, so it's very easy to follow. So thank you very much for that. If councillors can read it and understand it, then everyone else should be fine as well. So that's good news. But what we will do, if that's okay, unless there's anything that you wish to highlight or flag or draw attention to over the next 60 seconds or so. Otherwise, we'll go straight to questions and discussion on the document. So completely up to you.
Happy to go straight to questions if people are happy that they've read.
Okay. Your willing assistant has put his hand up. So Mike.
Go on, Mike.
So thanks. I'll chew up the time then. Just by way of background, really, what I was going to say was, we transferred over from the NHS to local government back in 2013. So there was a slight embarrassment on my part that it's, June 2022. And as you said, Chair, it's the first public health strategy that we've done. Just in case you think I've been really slack the last 9 years, the point is we've always had a health and wellbeing strategy through the Health and Wellbeing Board, which is a county council document. And actually all the way through, I think we've always kind of said, look, the public health strategy for Leicestershire is the health and wellbeing strategy, which is fair enough. In support of that, we've had various strategies which have been to Scrutiny, the sexual health strategy, the substance misuse strategy, etc. And Adrian's led on developing our service delivery directory of the services that we deliver in-house and the ones we commission. Increasingly, though, you're just aware that Adults and Communities Department publish their own strategies, children and families do. Just felt there was something about articulating as a department within the council, separate from the health and wellbeing strategy, a sense of what we're about in public health. So Adrian will cover, I'm sure, in questions kind of what lies beneath, but there's a sort of a reassurance that we haven't been twiddling our thumbs for 9 years, and also to kind of maybe nest this in terms of where it fits in terms of what we believe in as a department, of which the first thing, which is that belief in communities and asset-based community development approaches, is really something that I think sets us apart from most other public health departments within the country. And then also it does, in terms of a purpose, give us something as we've got this kind of integrated care board developing, as we've got the strategic plan for the council developing, we've got an easier read document to kind of go into the partnership agenda and articulate this is what public health is about as a department within the council, not necessarily as public health as an entity which you've also knew. So that's hopefully just over 60 seconds from me.
Thanks, Mike.
Louise, do you want to open up as well?
Yeah, I just wanted to say on top of that, we're trying to get health across the board in all policies. So it's really important that all departments understand what public health is trying to do and has been doing. And I think it's really important at this moment in time as well, with ICS coming on board and different partners working with each other, that we have that document in place.
Absolutely agree. Thank you very much. Okay, look, I'm going to open up to questions. Mrs. Page, you're back from tea and ready to bowl another over.
Yes, 2 questions only. But first of all, Mike, nobody thought you were sitting for the next. I mean, after the wonderful job you've done through the pandemic, we admire you, we and all. Question number 1, it explains what public health is, and you have 3 mantras. Now, in page 71 and all, you say how we do it, but looking at the previous report, especially agenda item 11, we so well scrutinized. I mean, nowhere do I see a reference to working with the CCGs and whatever else to improving people's health and, you know, whatever else. That's question number one. Then the very good document, and it must be good because I do understand it, Chairman, and I like the pictures. We're talking about sex, smoking, you know, rock and roll, but we've not addressed the drugs issues. So within the guiding principles and within the health issues, drugs, to me, it's one of my soapboxes. It has underlining issues. The prevention's got to be there. Drug abuse does affect health issues long term, and it is a serious issue. Yet we are talking not about prevention, and it is not even mentioned under the legislative aspect. So we're just talking about recovery, and then, you know, how wonderful and what we're doing about recovery. So personally, I don't think we should be highlighting the recovery, and that is the end stage. Somebody needs to want to give it up in the first place and need to want to recover, and then the chances are very high. So where's the aspect? Legislative, preventative, trying to get drug reduction, drug usage, a reduction in drug usage. Thank you, and very, very good document.
Okay, thanks a lot. Who wants to say that, Adrian or Mike? Mike's got his hand up.
Yes, yeah, so do you want to take the first question, Mike?
Oh, yes, fine. No, you're here to answer all the questions. The CCG one, I was just having a look through. Actually, it's a fair comment because we do support clinical care groups in the past, and it will be the Integrated Comfort Care Board. I can see mention of supporting ICS colleagues to embed public health data into system plans, which is on that page 71. So it probably forms part of the broad piece that is around working with partners internally and externally to address wider issues. There is, I suppose, a specific thing around healthcare, public health, which is the work that colleagues like Liz Orton and Barity in my department do, which is actually sort of the hands-on work with our clinical NHS colleagues around their pathway redesign, their needs assessment, and the everything else. So it is a big part of our work, but it's probably not reflected in the departmental strategy as well as it should do. I think there's more of that in the joint health and wellbeing strategy, and I suppose what we haven't done, we've left it to the NHS in the joint health and wellbeing strategy to say what they're doing around service redesign, capacity improvements, design reduction. We haven't acknowledged the role that we play in terms of being their, well, partly their data geeks and also their knowledge experts around service redesign and clinical pathways. What do you reckon, Adrian?
Yeah, I was just going to say, I think we've tried to cover it in the partnership working without really explicitly saying that talking about CCGs, acknowledging that CCGs are becoming part of the ICS, and we talk very broadly about what that support may look like. Because the ICS is still emerging, it's not fully in place yet, it's really difficult to be able to articulate fully what that support is going to be. So we've tried to keep it as high level as we possibly can. But one of the things that I was going to come on to later is that there will be a year-on-year delivery plan that sits underneath this strategy that will have much more of the detailing around some of the things that you've already highlighted, specifically around what that relationship between local authority and health will look like and at what levels, understanding that all parts of public health work with all parts of the NHS at different levels. So that will be much more articulated in that document than being as explicit as that in this document.
Actually, you just got me thinking, you know, it's easy for some of the health improvement lifestyle stuff because I can point to a substance misuse strategy and go, that's where the detail is, and then we've got the delivery plan. It's been a while since we wrote down the service level offer from public health in the local authority to the clinical commissioning groups. You know, there used to be that MOU that used to sign off. We could probably just need a small document that actually outlines what our offer is, because it is a statutory duty to the integrated care system. And there's loads of good stuff in there. I was thinking with the cancer one, Barty's been doing some great work with Charm with PCN around working with their patients to understand why they don't come forward for cancer screening, working with, for instance, Eastern European community about why they don't come forward. So it's not just about sort of data. There is some real hands-on stuff that we're doing with the health service. So all of which, at the risk of writing another strategy, just a 2-page actually sets out how we work with them, would probably illuminate that a bit better. Whether we stuck it in there, or whether we did it as a separate.
Brilliant, because this is the Bible to most people.
Okay, thanks a lot. Mr. Harrison.
Mr. Chairman, you're probably not aware, but the authority's working with an organisation in schools called Prevent that I've been involved with the deputy leader of the council regarding knife crime. And I've gone along with, the two of us went and watched this and experienced it in a school, the debates and how the students were able to debate and understand. And I thought it was exceptionally good. Now, because drugs are really, really massively important, and particularly in a young age group that was mentioned earlier on, I think maybe this could be a way through, a pathway, because this organisation is a start-up. It originated from Scotland, and I think there's a potential that if there was a programme that we could evolve, or they could develop this programme, that we could start to deal with it. Schools are critical. It's where the forming of young people's minds and attitudes, and I think that would be absolutely brilliant, because I've watched it work. It runs, it talks, it's got legs, it can move. We just need to find something appropriate, because I think there is a need, and that would be amazingly good. What I'd also like to say, Mr. Chairman, that the report is so different from number 11. I mean, the director's played a blinder, bringing anything in other than 11, because 11 was very tough. But this one, I really like, puts residents' needs at the heart of the community. When you look at how they promote, protect, provide, this isn't about finding other ways and talking about how we can excuse ourselves in a nice way. This is about getting stuck into it, really into it. And all I can say is well done. The work's not completed, it never will be. But hey, what a great task force going forward, and what good initiatives, good quality, and I congratulate you on that. But don't forget the Prevent, because that's really important. Thank you, Mr. Chairman.
Okay, Mrs. Richardson, do you want to come in?
Yes, thank you for your comments, Councillor Harrison. I'm very proud of what the team are doing at the moment, and very proud of this strategy. We do input into children and families. We're not seen in isolation. We work very closely with children and families with the Healthy Schools Partnership, and also going into adults as well. So there are education programs going through. It's probably just not highlighted specifically.
Yeah, and the other bit for me is think about prevent and knife crime. So back in the old days when we first came over, our input into community safety was really just about being commissioners of the substance misuse programme. Now, Joshna Mavji in our department is a consultant lead for what we now call safe communities, because her portfolio spans such a lot of services around domestic abuse support. There is the substance misuse, which isn't just alcohol, it's drugs as well. It includes, going back to Mrs. Page's initial question, it's drugs and alcohol, and it's also about prevention in the first place. Josh has then been plugged into things like the LSCSB, the Community Safety Board for Leicestershire. I've just been invited onto the SPB, the Strategic Partnership Board exec, the one that's chaired by Jane Moore. And Joshna had quite a lot of input into the Violence Prevention Network when that was starting off, that the police put together, which obviously was looking at knife crime and other crime, and taking a public health approach, looking at not just dealing with the sharp end, no pun intended, but the causes and the causes of the causes and all that kind of jazz. So Joshna's made some really great links, I think, strategically, and we've definitely got better joint working across the council, particularly with children's. around community safety and violence more generally. If there are programs that we're not aware of that we need bringing in, then actually we'll build on the good stuff that we've done before. But I think that's one of the things that has evolved over the years. Is when we first came over, we were sort of holders of a particular group of services and responsibilities that transferred over. But over the years, given the good working within the council, we've kind of expanded that into sort of proper public health work, which should be dealing with everything. And thanks for your comments. It's not the director that played a blinder. It is Adrian that wrote the report. So it's all is. To paraphrase Brian Clough, you know, the secret of good management is just to appoint good people. So that's.
Okay, look, thank you very much. Before it gets to be too much of a thank you fest, Mr. Hills.
Just a very simple question, so forgive me for my naivety, but I've got to ask, because you said how important it was. What actually is an asset-based community centre approach?
I think, Adrian, that's definitely one for you. I think that's just been passed over.
I thought so. So an asset-based approach is looking at what's already in communities and working with those assets to be able to support communities to evolve. So historically, when we think about assets, we always think about buildings and physical things, but this really is looking at individuals as assets. And there are so many assets in communities that we already work with, whether these people are identified by their communities as being you know, someone who is supportive or has a special skill in some aspect that can support people. And it's about really identifying those people and embedding those further into the community so that the community knows where to go for support. So this is about building resilience from within, without the council or other organisations having to do things to communities. It's about supporting them to be able to identify and support themselves. So that's really the fundamental elements of that asset-based community development, is to start with an asset and then build from there.
And a number of reasons, number of reasons for doing that. One of which is a belief in self-help, that communities are best placed to support themselves and to solve their own problems. If I was honest, it's a bit driven by austerity as well, because the cheapest way of doing things is, rather than put in place high-cost services for people that fall into dependency, is try and put in place a lower cost, because they are good value support within communities, so you stop the problems happening in the first place.
Okay, thank you very much. Mrs. Newton.
I was looking at page 63. I mean, my background is research on carers from the university, and I noticed that only 30% of adult carers have had much social contacts, and as they would like, and that's as opposed to a national figure of by 35%. And I just wondered, what has the impact of COVID had on that, and what factors we can bring into play to ensure that there's better social contact for these people who are really living in isolation, and they do suffer badly from depression. And well, you know what it's like for them. They're looking after people that are quite stressed out, and they themselves will have problems too in terms of health and other problems. So I just wondered what more we can do to increase social contact, help them to increase their social interaction. Thank you.
Yeah, so I was going to say, do you want me to take that in the first instance, Mike, and then you can?
Yeah, cheers.
Just talk about that. So we already know that COVID has had a huge impact on carers, and they're one of the groups in communities that we have some particular concern about, because they're a group that, as you've quite rightly pointed out, tend to be isolated anyway, and COVID has just exacerbated that issue, because they've been protecting themselves and the people that they care for. So we are aware that 30%, the data that sits behind that 30% is probably just as we were going into COVID, so it's likely to be worse than that now, although the data in the national database hasn't been updated yet. What we're doing on the ground in real terms is that we've got our local area coordination programme that works in communities and is embedded in communities. As I said, carers are one of the groups that they are particularly looking out for in terms of that. They're working really closely with adult social care colleagues to be able to identify carers and almost do some targeting with those individuals and communities. We've also got our community recovery workers that are looking specifically around the effects of COVID with communities as a whole, but also working with individuals. And again, carers come into their focus when they're working with specific people as well. What we're trying to do with them is work with them again with this kind of ABC model, but looking very much at what they need as an individual and what they think will help them, rather than trying to force them into going to groups or connecting with other people. So it's a real one-on-one type conversation, but really starting to encourage them to come out of the home and to support them with identifying services and support that they can get from adult social care or other parts of the community and the system, to be able to get time for themselves, because obviously we understand the importance and the value that they place on that. So there is quite a bit of wraparound support for those people at the moment, but there's always more that we can do with carers. They're always going to be a group of people that, unfortunately, because of the nature of what they do, are relatively isolated.
Yeah, thanks. There's a couple of things from me on that. Well, one of which is, correct me if I'm wrong, Adrian, I think ITV are filming the community recovery team this afternoon.
They are, yes.
An innovative piece of work around supporting people who maybe have felt unable to rejoin society after COVID.
Yes.
The other bit is specifically around that indicator. I'm just trying to look through the next item, but I thought carers isolation was one of the things that was mentioned on the next agenda item performance report, and it might be that we pick up a discussion which isn't just about our services, but more generally with adults, how we support carers.
Yeah.
Okay, thank you very much. Look, we haven't got any more questions, so thank you very much, Adrian, and also to your proofreader, Mike. Really good report, really good strategy. Good to see that it's coming through. Great to see that we're sort of making a move on this to push it forward, etc. So thank you for everything.
Thank you.
Okay, right, we're now going to move on to the final item of this afternoon, which is item 14, health performance. This report is submitted. I can see Andy Brown on my screen. Excellent. So this is Andy, who's BI team leader here at the County Council, and also Kate Allardyce, who's NHS Midlands and Lancashire commissioning support. So welcome, Kate, as well. I have to say, I haven't come across many joint commissioning areas with Lancashire before, so always good to know that we're branching out. So very good to see you. As usual, we take reports as read. This one in particular, I have to say, I described it as a tsunami of data, in the sense that there is everything and anything that is quantified and measured, a lot obviously against national data as well. I think one of the we'll unless there's anything particularly that either of you wish to highlight that's new from the report that's been published, we'll take the report as read, unless there's anything that either of you wish to actually say. Otherwise, we'll go straight into general discussion and questions, if that's okay with the two of you.
Yes, thank you, Chair. Just 30 seconds from me and possibly 30
Absolutely.
seconds from Kate, just on new elements. As you say, it's the performance report on the Public Health and Health System Performance Framework, including the BCF, based on data in May. Some new areas we've included, some extra information around the LLR, health system governance and design groups and quality group, which I think particularly new members will be interested in, some of that underpinning new performance and improvement framework and processes, particularly as we move to the new ICS system fairly quickly now. So that's new information there. Also in Appendix 1, we've included some new information around the cross-cutting priority around health inequalities and the health inequalities framework. So that's all set out in Appendix 1. Appendix 2 is also a new style performance report, particularly focused on the new health and wellbeing strategy. So we've got a comprehensive set of outcomes and metrics that attach to that strategy, and that's really to help you see the impact as the strategy and the previous strategy on the agenda works through, so you can sort of track those metrics and what difference is being made. And also to help identify any particular issues you might want to ask for particular reports on moving forwards. It's very much part of our assurance and governance arrangements. So that's a quick intro from me. Kate, did you just want to say anything quickly on your elements?
Thank you. Thanks, Andy. So just wanted to pick up really from paragraph 13 onwards, which relates to the health performance metrics. So we've sort of focused on 5 particular metrics here, which were the Nhs Constitutional Metrics. And those of you that have sort of been on the committee for a while will probably recognise these. But these are a very, very tiny subset of a much wider and much larger set of data and metrics that we report on. So NHS England has a framework called the Nhs Oversight Framework, and there should be a link in the document to that. So again, just for new members of the committee, and to let you know, there are about 80 metrics within that framework. And obviously, we're not going to be presenting all of those to you, which is why we've picked out those sort of 5 constitutional metrics. But also there are other metrics that we report locally, determined on what local priorities are. And a prime example of that is around discharge. So, you know, there's a concern locally around the number of patients that are being discharged, or, you know, we kind of need to get patients out of the system as sort of as quickly as possible, but obviously as safely as possible. Now, discharge isn't a national metric, so in theory we wouldn't necessarily report on that, but obviously we see that as such a priority locally, then it does go through the numerous committees that we report to on performance metrics. Just a very quick update in terms of one of the cancer metrics. So I think within the paper we've got the March position, we have now got April's position, and we've seen quite some considerable improvement on the 2-week waits for breast symptoms. There is a real issue nationally over the last few months in terms of that performance, but we have seen a real improvement in April's data. And just very quickly, finally from me, the last paragraph, sort of paragraph 19, really talks about some of the challenges, talks about the improvement, some of the areas that we've seen some improvement locally. And, you know, I think it's quite easy to focus on the challenges that we've got, but also we need to be mindful that there is some green shoots of recovery out there. We've talked about the number of GP appointments. We're actually the only ICS in the Midlands that have got no inappropriate out of area mental health placements, and we've had that for the last 8 months. So there is some positive news out there that I think members just need to be mindful of as well. Okay, I'll leave it there, open it up for questions.
Okay, thank you, Andy. Thank you very much, Kate. Kate, can I just quickly open with a question about some of the comparative data? So under sort of section 13, you started to talk about some of the sort of statutory headings on comparative rates. So, for instance, cancer 62-day referral, national targets 85%, etc. Right. Admittedly, these are March figures. East CCG is 51, West 50, so comparably similar. Can I ask you about? I mean, obviously these are all against a national target, and I appreciate your role actually is probably quite helpful in the sense that it's a much wider geography. Is there any way of actually looking at comparable data with sort of regional areas? Because whilst the national target is helpful, I suspect that probably that national target predates COVID, unless I'm wrong, in which case I very much doubt that anyone in the country is probably even coming close to 85%. But it would be useful to actually understand how other areas are managing. In particular, if there are some areas that are doing extraordinarily well against some of these metrics, understanding what they're doing well, how they're managing to outperform other areas. And it's you know, we get very used to actually just looking at Leicestershire or the national figure. What we lose sight of is possibly other areas around the country that might be comparable, or alternatively might be doing something that we're not doing.
Yeah, so we do a considerable amount of benchmarking, and we can do that against Midlands organisations, but also NHS England have set up what they call peer groups. So, for example, if we were looking at a CCG group, then they would group similar in CCGs in terms of population demographics, size of the population. So we have a list of about 10 different CCGs that, for example, West Leicestershire would then be sort of matched against. So we can do benchmarking in those sort of 2 ways, either geographically or which is probably more useful, the peer group. And again, as long as they're national metrics, then there is a system online that we can go on and we can download data and look at the comparisons that way. And as you quite rightly say, then look at the areas that are performing best, particularly if they're within our peer group, because they should be very similar to us, and then, you know, sort of make contact. And that happens with CCG staff that are involved in those particular disease areas.
Okay, thanks for that. Right, I'm going to open up for questions in that case. Are there any questions on this? I'm looking at no hands up at the moment. Right, Mrs. Page.
Not on the indicators because, as you just said, Chairman, it's a tsunami and I'm not sure whether I like a lot of them. But can I just have a question on the Better Care for All framework structure? Now, it goes back to the questions I've asked earlier on. In there on page 113, it goes restore NHS service inclusively following the impact on NHS. And then on one of your what's it actions, whatever you call it, 9. It is just generally, and it hasn't got anything in improving patient experience and access. So, you know, just give me your comment on that. And then my other pet hate drugs, if we're talking on page 108, what is health? And we are talking mental health, which is in your principal action number 4, or whatever you call it. Now, yet in the social model of health, mental well-being isn't included. And I would have thought that that is very, very important. So comment on that. And on this page 107, it has got like the snake thing in, and it goes, it refers to alcohol related hospital admissions. Well, why aren't drug related hospital admissions? And I'm sure there's quite a few not included. Thank you very much. And
I can take that, Andy, that's fine. So this is a document that was written by, well, with partners by the Health Inequalities team at the CCG. So what I'll do is I'll forward your details, if that's okay, to Steve McHugh, who provided the document. I do think it's probably gone out quite widely for consultation, but again, Mike, I don't like to put you on the point, but on the stand, but I don't know if there's anything you've been involved with in terms of that document.
No, not directly. I suppose the point for me is, of course, it's all LLR. So coming back to our own dashboard and our own health and wellbeing strategy, I'd have to look through it. But, you know, that's where I'd like to see the kind of, I'm more interested in inequalities within Leicestershire than I am across LLR, if I can be blunt.
Well, it is just a general comment because those are quite important to me. And if you're looking at that, you know, it's just a general comment. If we are consulting, then those points should be highlighted and raised. And if you can feed them in, you know, you don't have to respond to me personally. Just note them and pass them on to whomever, you know.
Okay, thanks a lot. Any other points or questions that anyone wants to raise? Okay, Mike.
Yeah, just one from me, Chair. I mean, sorry, maybe on behalf of the board, I can't help but see lost it because I'm on the other document. It just harks back to the earlier question about the impact of COVID on cancer, and it looks fairly stark to me, really, that much as Dave was reassuring about where the screening programs are now in terms of recovery, that's a field of reds, and that one, which isn't about screening, but the 62-day wait from screening to treatment of services. I think it's down as a target, it's 90%. It looks like we're averaging about 63. So there's almost a kind of going back to where we started off with the substantive reports, which is, I think that tells quite a lot about what the impact of COVID's been.
And I'd also point out that actually one of those boxes shouldn't be red, but clearly the general assumption is that everything should be red. So it's a good point, which is, you know, how comparable is that to other areas? and B, you know, how are we going to actually turn that around? Because it is something that obviously everyone's been focused on for the last 2 years.
If I can just make a very quick comment, I'm sure if the Cancer Design Group were here now, they would talk a lot about the increase in referrals that we've had over the last sort of 6 months as people have kind of gone more to their GP, and sort of the levels of diagnosis following those referrals as well. But again, it might be something you want to look in a bit more detail at a future HOSC, and there certainly are experts across the patch that I'm sure would be willing to discuss that with you.
Okay, I think we'll raise that at the agenda setting meeting and see what we can do. Okay. Right, any other points? No, I can't see any other hands up. So look, thank you very much, Kate. Thank you very much, Andy. We will draw ourselves down from the tsunami of data that's washed over us and try and look back on it, I think, probably over time to pick out the relevant parts that will support some of our future discussions. So thank you very much for that. Look, thank you very much also to members. We're now on to the next item, which is item 15, date of the next meeting. That is, in fact, the 31st of August at 2 o'clock in this room, no doubt with the curtain still shut, so come prepared. Item 16, which is urgent items. There are no urgent items, so in which case I'm happy to declare the meeting at a close. Thank you very much. Thank you.